Hi, hello, everybody, and welcome. Welcome back to the third session of the STAR Center Summer Webinar Series, Administrative Strategies to Reduce Burnout. This week, we will continue to delve into the search of joy in practice. My name is Mariah Blake, and I'm the Program Manager here at ECU. I'm joined on the line once again by our presenter, Lisa Hardmeyer-Gray, and this week's guest speaker, Raul Jatar. We have a few quick things to go through, as usual, before we get going. So this webinar is brought to you by ACU, the Association of Clinicians for the Underserved. We're a national nonprofit focused on the recruitment and retention of clinicians in underserved areas. We're always striving to improve care for our underserved communities, and we hope that this webinar series has been enjoyable for you all and that you're able to take some of it back to your organization. Below this ECU is the STAR Center, our workforce project that provides training and technical assistance and resources to help health centers improve their recruitment and retention strategies. You can check all of that out on our website that's listed on the screen right now, chcworkforce.org. And you can get in touch with us after the webinar if you'd like to follow up with anything on that website. So like I said, my name is Mariah Blake. I'll be handling the technical side of today's webinar. If at any point you're having technical issues, your connection is messed up, any of that, just shoot me an email at my email on the screen there, mblake@clinicians.org, and I'll try and help you out. If you have any questions about this presentation or any of our other STAR Center activities, feel free to contact myself or Suzanne Spear, our Director of Workforce Development, whose contact information is shown on the screen as well. Like I said, just a few quick points before we get going. We are recording today's webinar. It'll be posted to our YouTube channel and onto our website and be sent out to you along with a copy of the slides tomorrow via email. So keep an eye out for that. Please ask questions. If you have a question at any point during today's presentation, feel free to drop it into the questions box or the chat box on the right-hand panel of your screen. You can also raise your hand to let me know if you have a question, and I can chat to you in the background here. Please stick around through the end. We have a really great presentation and a short evaluation afterwards that we'd like for you to fill out to give us a bit of information about how you thought today went and how we can improve in the future. Okay, now that we've taken care of that bit of housekeeping, I'll get out of the way and hand the floor over to Lisa. Thank you.
Hi, thank you, Mariah, and I want to thank everyone again for joining us as we continue this exploration in search of joy of practice. In the last episode, we looked at, let me look forward that. Yeah. Okay. In the last couple of episodes, episode 1, we looked at what is burnout, how to measure it, and how to start thinking about addressing it in your organization. And then last week, we began looking at the study In Search of Joy in Practice, which we're going to delve into a little bit deeper this time. Next week, we're going to look at workplace wellness and how to create a culture of engagement. And then episode 5 will really be looking at self-care. So this week, again, looking at how to rethink about prescription renewal, inbox management, improving team communication, and we're going to talk with Raul Jatar quite a bit about workflow mapping, how to create the innovative strategies within your organization and how to really bring that to your organization. And then looking at some takeaway recommendations by the authors. So again, going back to the study. The study is listed on the right. I hope that everyone is getting a chance to look at the study more in depth, and this webinar really highlights the work of these authors, looking at 23 high-functioning primary care practices. They looked at practices across different geographic regions, FQHCs, small private clinics, large integrated delivery systems, academic medical centers, the VA, And they went to each of the sites, followed them for a day, shadowed practitioners, talked to staff. So it was quite a robust study. I encourage you all to not only read the study itself, they did an excellent white paper. There are PowerPoints available with Q&A, so lots of supportive information. I'm going to really just go over the highlights today, but some of the more detailed information that's available has action items, regulatory issues, insurance concerns, and there's up to about an hour and a half on YouTube of a great presentation, and then the Q&A. So again, just highlighting the challenges they found across these 23 different primary care associations, chaotic visits, EHR that pushed more work to the physicians, not having enough support, the frustration of too much time spent documenting, and then the teams that function poorly. So those were really the 5 key challenges. And in a nutshell, the innovations that they found, and we went over the first 3 last week in part, the pre-visit planning, pre-appointment lab test, sharing care among the team, which we're going to go into more this week. We had a great conversation with Dr. Carolyn Halley about the STAR² program here at HealthPoint. Today we're going to touch on assistant order entry, and then looking at other ways to think about prescriptions, management of the inbox, more on communication, and then the workflow mapping. So those were the innovations they found as they traveled across these 23 primary care organizations. So going to just touching back on where we left off last week, we talked about the STAR² program quite a bit and some of the results that can be had there. Physicians are spending up to 2 hours a day outside of the office. So just a quick poll question. I'll turn it over to you, Mariah.
All right, yeah, you should be seeing a poll question on your screen now. If you chime in and let us know who in your clinic is responsible for entering orders, preparing the after-visit summary, and going over the care plan with patients. So we'll leave this open for another couple of seconds to give people a chance to chime in. All right, just one more second there, and you should see the results on your screen.
Any of the above, okay. Okay, so it looked like the majority was still in the primary care world, and again, these are 3 different things: the entering orders, the after-visit summary, then going over the care plan. But it looked like for the bulk of you, that still is on the table or on the plate of the primary care provider. So can I get the next slide? Thanks. So this is really talking about empowering MAs, and this isn't just MAs, but nurses as well, or health coaches, to be an integral part of the team. Having everyone work to the top of their license. So who in your organization by license can enter orders, and to what extent can they enter orders? Preparing the after-visit summary and going over the patient plan. I've talked to a couple providers here who feel that that's really part of their job, is to go over the patient plan. And so I just want to challenge you as we go through some of these innovations that really they're talking about a practice redesign and moving away from the sole focus of the responsibility and the connection to the patient being with that provider, to stretching it out to the team and expanding the roles of the team, expanding the responsibility of the team, and the physician shift that has to happen to really rely on and pull in more parts of the team. So like last week, I'm going to just go over a couple of case studies or examples. And again, some of these are pulled from private clinics that might have probably more than likely have more resources. But when we're talking about innovation, it's important to understand and have examples across the spectrum. What pieces could you pull out? What might be possible that you didn't think was possible in your clinic, because we're kind of hemmed in by how we think about budgets and revenue. So this is a study that was done, or a clinic called Newport News. And there's a doctor there, Dr. Peter Anderson, developed a family team care model in 2003. And that was in direct response to just an increasingly unsustainable workload. And in the old model, the doctor and the nurse or the MA, they went their separate ways. And in the new model, the tasks of the nurse or MA and doctor are tightly woven together. So as part of the rooming process, what they do here is the nurse, in this case, they're working with the nurse, reviews recent clinic notes, collects consultations, the ER visits and labs, clarifies the patient's agenda, documents all the patient's initial relevant and current medical data using the structured templates, and performs a condition-specific review of systems and enters the information into the EHR. This is now taking 8 to 12 minutes, which is a little more than just your MA rooming the patient. And after this part with the nurse or at MA, the actual doctor and nurse come into the room together. And in this case, Dr. Anderson greets the patient. The nurse verbally relays the reason for the visit, kind of like it happens in medical school with attending or the resident giving the update. And then the doctor asks the clarifying questions of the patient, performs the exam, verbalizing abnormalities, which the nurse documents into the EHR. In the example last week, it might be the scribe. And then the doctor spends the rest of the visit talking directly with the patient and the family. And the nurse or the MA, to the license they can, performs the order entry, sends the electronic prescriptions, and enters the diagnosis code and notes the interval for the next follow-up appointment, which the patient then gives to the schedule. So while the nurse reviews the after visit summary with the first patient, Dr. Anderson then moves on to the next patient with the second nurse or MA. And again, we're going to talk about in this clinic, and again, this probably is a luxury, there are 3 to 1. So it's 3 support staff to 1 physician. And before we really think about, is that possible, we need to ask the question, if a physician is happier and can potentially see more patients, can those that increased revenue by seeing more patients, can that be shifted to more support staff? And then, really think about, what is the cost of burnout? If we lose a provider because they're burned out, how much does that cost the organization? I'm not in the budgeting department, so again, these are questions to take back to your organization, but just some new ways to think about the innovations. And this model that this Dr. Anderson created, he took it out and began training U.S. Army primary care practices in this model. Okay, so okay, then another example I want to bring up is, it's called the Office of the Future. And in this example, this is from Quincy Family Practice in Quincy, Illinois. This was a pilot at Southern University School of Medicine. And here, there's not even a doctor doesn't even have a desk or computer in the room. He sits on a rolling stool and attends directly to the patient. The number here is 2 MAs, 1 nurse. And the MA reviews a pre-appointment questionnaire in which the patient's asked, what 3 questions would you like answered today? She completes the medication reconciliation, begins recording the HPI, working through a structured history for each complaint or condition, checking off the boxes, adding free text as needed. Again, this could be with the scribe. And depending on the complexity, this again may take 18 to 15 minutes per patient. And the process generates components for billing and frees the physician from sitting on the keyboard, and really puts the patient and the doctor more in touch. When finished, the MA returns to the nursing station and briefs the doctor. So the doctor comes in, returns to the room. And unlike the first minutes in most physician office visits, and we can probably all relay this to our own visits with our own doctors, the first few minutes are spent in front of the computer. In this case, the doctor can move directly to the patient or any family members. There's no signing in, orienting the visit around the computer. The physician's full focus is on the patient. And the MA is sitting in the room, listens to the physician, and supplements the history she recorded earlier. So the MA is able to move between the templates for recording the history and an exam, and maybe she'll get a little bit behind. She can jot a few notes, he or she, and then always able to catch up. This is what they observed when they followed this model. And finally, in this case, it's Dr. Kim. He verbalizes his assessment and plan, which the MA also records, writes the diagnosis and plan, queues up the prescriptions, which the physician signs between patients, and then checks off the lab next appointment information for the patient to take up to the scheduler. So in this case, this physician and staff actually find they've had much more time. The results are there's 30% more access to providers. The costs were covered. The satisfaction of the staff and the physician increased, quality metrics increased, and physicians left home an hour earlier. So again, you know, how this fits in financially in clinics that are Medicaid and Medicare and more reimbursed, that's a question, but just start to think about these innovations and how can we maybe shift some of these costs around. Because ultimately we want a little bit less of this and a little bit more of this. I know when I first came into primary care, I'd come from a completely different industry, and it was just surprising to me that nobody goes out for lunch. Maybe some of the MAs do and the front desk staff, but in my clinic, a lot of the physicians eat lunch at their desks, and you know, we miss that kind of camaraderie and that little bit of a break in the day. Okay, so we're going to move on to the next challenge. So much about the computer age, we thought we were going to be saving so much time, and that's obvious in healthcare. What we thought might have been time savings is actually creating more work. So a lot of the technology is pushing more work to the physicians. And so the innovations that we're looking at here are, how can we use technology to save time and improve communication? And how can we reduce the unnecessary physician work through inbox management? So I'm going to share another example. And this is at a clinic. Well, actually, this is at Group Health, which is now Kaiser. But at Group Health, with the medical home transformation, Group Health decreased the patient panel size from 22 office visits a day to 14 face-to-face plus 4 telephone visits. And we're going to get into some of the other electronic possibilities. But 1/3 of patient encounters now take place through the patient portal, My Group Health, and time slots are available for desktop management. And this can include responding to patient emails, sending secure messaging, coordinating care with specialists, hospitalists, and addressing many staff messages coming from other members of the team. So a typical hour in clinic might involve 2 pre-scheduled 20-minute visits, 1 20-minute slot for desktop medicine and phone calls. In this case, at Group Health, the physician burnout dropped from 25 to 14% in the pilot clinic, while burnout increased from 28% to 35% in clinics that had not changed the template. So really thinking about how can we save physician-only work for physicians and put much of the non-physician work to the support staff. Let me ask another quick polling question. We're going to look into prescription renewals. So Mariah, I'll turn it over to you for the poll question.
Thank you. Yeah, the poll question should be up on everybody's screens now. We'll leave it open for just a few seconds to get everybody a chance to chime in. We're asking, what is the average number of prescription renewals a provider handles in a day? All right, just a few more seconds for everybody to get their word in. All right, great. Thank you, everybody.
Okay, so most people answered between 5 and 9. The answer is actually 10 to 15. So this is a large area of unnecessary provider time. Physicians spend approximately 30 minutes a day on prescription renewals. So really starting to rethink, that's a lot of time per day. That's a lot of time per week. How can that be shifted to other support staff, to nurses, to MAs? One example here is with a organization, Alina. And there what they do is the medications are renewed for a full year at the annual exam to avoid unnecessary interval handling of stable prescriptions. For example, a 3-month supply with 4 refills covers the patient until the next annual exam, and prescriptions initiated at interval appointments have refills remaining. And at another clinic, the patient care is organized around an annual comprehensive care visit or the annual wellness visit, and prescriptions for all medications except narcotics and benzodiazepines are renewed until the next comprehensive care visit. The patient will also be seen for scheduled and acute care visits as needed throughout the year, but the staff doesn't need to repeat the work of prescription renewal of chronic illness medications at these interval visits. And in this clinic, the process of synchronized bundled prescription renewal once a year resulted in an 80% reduction in the overall time team members spend on prescription renewals. And that's not to mention the quality of care from patients. I heard an example last week with a mother trying to get her daughter's prescription for sertraline refilled. And she called the clinic twice. This is a private clinic, called the clinic twice, sent an email and a phone call, and never heard back. So over the weekend, ended up in urgent care trying just to get a prescription of sertraline, which her daughter had been on successfully for several months. So it's not just the cost savings to the clinic, but it's really better patient care. And then let's look at some other technologies to improve communication. We've all gotten so used to communicating with each other by email, we forget to actually pick up the phone, talk to each other face to face. And what they're finding over time, the research is finding that this is the Group Health model that I talked about. But what they're finding over time is that verbal communication is actually more efficient than the amount of time spent on trying to task people who are in other rooms, that really, by co-locating, which we're going to get into, having the ability to talk face to face. So this goes back to the group health model that I just mentioned, decreasing the face-to-face visits, using more of the patient portal. I'd be curious how many organizations are starting to move into telemedicine. I know Kaiser, again, is starting to move into texting. So really leveraging technology to increase what other support staff can do, building that team. Sorry, I'm having a little bit of a hard time with my mouse here. Okay. This is another area that they found innovation around, inbox management, and getting, again, the support staff coming in to filter out anything that is not urgent for the, or not urgent, but unnecessary for the provider to be doing. So nurses or MAs filtering all electronic and paper information involving the physician in only what is required. So filtering out normal lab results, prescription renewals, returning patient phone calls, anything that can be done by support staff. And I'm going to give an example here. One clinic called Fairview, that I've mentioned a few times, they had quite a few innovations. Fairview had decreased the number of inbox work for physicians from 90 minutes to only a few minutes per day for many of their physicians. So all the messages were first directed to the MA or the nurse, who filters out these items listed. And electronic messaging is often replaced by more time-efficient verbal messaging between the clinic physicians and the assistants. And the goal is for the physician to see and do only physician-level work. And the next challenge we're moving into is teams that function poorly and complicate rather than simplify work. So when we're talking a lot about this verbal, the verbal communication being more effective than a lot of the electronic communication, talking about moving teams together through co-location, huddling together daily, regular team meetings. We're going to save the last two a little bit, but just really focusing on the team communication. So here's a picture of kind of a morning huddle in the exam room. The IHI has a lot of great examples of models that are co-located and, you know, having line of sight so that the MAs and the support staff actually can see what's going on in all the exam rooms as things are happening in real time. So having that line of sight. Even co-locating the scheduler, including, and not just the scheduler, but all of the support staff, all of the providers. In this clinic, we're lucky. We have acupuncturists, nutritionists, clinical pharmacists, the behavioral health. We're all in several pods, and we do a lot of talking through the day about our patients. And you know, for me, I came from another clinic where I was in behavioral health, kind of sequestered in a back office. And when I made the move here, I was so excited about functioning more as a team and not being kind of in this isolated area. and just the shared learning and shared patient care that happens when people are co-located in a team. I'm going to read it or talk about an example here from another physician. Again, this is a private physician group, but in this office, the MA and the physician sit side by side in what are called flow stations. This is at North Shore Physician Group. And the change in geography has resulted in an enormous cultural change, says one of the director of the clinical service. She considers herself the flow master. The MA is the gatekeeper and is tasked with sorting and filtering all the electronic and paper information to reduce the burden on the physician. And part of the MA's role is to ensure that the physician is in flow and on time. So it really becomes the MA's responsibility. So as we're shifting really some of the shared burden of responsibility for this onto the support staff. And one of the early adopters of this program was an established physician with a very large panel, 2,500 patients with high complexity. And prior to the new model of co-location, he took 2 to 3 hours of work home each night. And now this same physician routinely leaves the office with all of his work completed. So you can imagine the impact that might have on burnout if a physician has that much more free time at home and really leaves work at the office, at the clinic. So I'm curious, Mariah, I'll turn it over to you for this next poll question.
All right, our final poll question, I believe, for our hour here. Do you have teams, including MAs, nurses, providers, co-located in pods? Leave this open for a few more seconds to get your input. All right, thank you, everyone.
Oh, that's great. 82%, that's fabulous. Yeah, and you know, when you think about kind of that co-location, that can be a big investment in infrastructure, in remodeling the clinic. So while I would imagine there are people who answered no to that question, who would very much like to reshape the clinic, you know, it takes an enormous amount, in some cases, of a reinvestment in the infrastructure. One of the things I didn't show a picture of, but it's out there, are just the type of desks that are available that are much more conducive, you know, oval shaped desks or half rounds where the providers on one side, the patients on the other, the computers in the middle. And, you know, oftentimes the physician actually has their back to the patient and is kind of going back and forth on this stool between the computer and the patient. So just the ergonomics of a redesign in furniture, office furniture, to make it much more interactive. And then I want to just talk briefly about another example of team meetings. I would imagine all of you are doing team meetings, but this is just a really good example to look at. This is another private clinic called Martin's Point. They do a daily huddle, which kicks off the clinic session, and it's attended by all members of the office staff. And one person serves as a huddle facilitator. This is rotated on a basis, you know, every day. It brings other people into the organizational, they feel more part of the organization when they're running these meetings. And the huddle begins with wows, opportunities for colleagues to call out great behavior or particular things that other staff did that really went above and beyond. In this clinic, we call them kudos, so we shout out the kudos. And the next is a review of the metrics from the previous day's schedule, such as the number of no-shows, unfilled spots, or any same-day cancellations that weren't filled. Questions like, were the patients roomed on time? How are they doing with, were there any walkouts? That's often a question we are asked here. And really starting to look at all the learning opportunities from the day, posted on an easel and followed up so that they become hardwired into the team's processes. And when we think about improving team, when we think about the innovation, where does the innovation in a clinic come from? Where does the innovation for change come from in your organization? Is it something that one of the leaders goes out and goes to a conference? Does it come in through support staff seeing a good idea? How do you really think about change, and where do the ideas come from? This is where I'm going to ask Raul to come in. And Raul is the Director of Kaizen Promotion Office here at HealthPoint. HealthPoint actually serves about 9,500 patients a year. It's a clinic that employs 825 people, I think. And Raul's been guiding HealthPoint's executive leadership since 2014 in the adoption and strategic dissemination of lean as the organization's management method, which many of you probably are familiar with and maybe use yourself. So Raul is instrumental in building the infrastructure for the in-house expertise in lean management. And he's also passionate about building systems internally that ensure great patient experience, transforming the culture and community health policy. So Raul, do I have you here?
Yeah, I'm here.
Okay, great. Okay, so I'm going to turn it over to you, and I'm just going to start out by asking you a question. When you're doing your work, where do you see the innovation coming from in the organization? Can you talk about kind of the breadth of where it comes from?
Sure. I mean, that's a great question. So in my observation, I think innovation happens at the front line every single day. It's just that sometimes we don't see it and we don't think it's happening. But what I'm going to talk about, the process flow mapping, is a great way to understand and see how innovation happens at the front line. And it's coming from people who do the work. They are subject matter experts, so they are involved in creating something. And lean management is just a way to harvest those ideas and really make things visible. So, what you have in front of you on the slides is it's a picture of one of the process flow mapping sessions that we had at one of the clinics, and it really is an evidence-based management method. Lean is an evidence-based management method. So all the things that Lisa was talking about, like the burden of time accompanied with the defects in care, like patient safety and patient quality, when you combine those things, that gives you a lot of data. And that's one side of the story. The other side of the story is to look at the process. So this approach of process flow mapping really brings a process to life. And I think we talked about co-location, and I think that's a great start, because when people are co-located, they have an understanding of what other people are doing when it comes to the same process. And this approach of process flow mapping really illuminates the areas of that process, and it really makes things visible so that people can see what's happening upstream and downstream. And it really highlights the burden of work on each and every person involved in that process. So it's a data-driven approach. It involves people who do the work. So it's not a top-down approach where some executive or some director goes out to a conference learned something and they come back with an idea and they say, hey, I want to change the workflow. This is really a bottom-up approach, and lean management is really like it's a democratic approach, where people are empowered to share their burden of work, make it visible, and really create that culture of trust and safety where they can see what's happening upstream and downstream. So at HealthPoint, we have a Kaizen promotion office, which I say is like the keeper of the method when it comes to lean management. But their expertise is used in facilitating these workshops. So when people from the Kaizen promotion office go out to the sites, they don't know the content of the process. They are not the subject matter experts, but they just use the concepts of lean management to engage the subject matter experts, engage the MAs, the providers, the nurses, the front desk staff, sometimes even the patient, in understanding what the experience is like, how it looks like to work in that process. And we really use that methodology to improve our process and improve patient safety and patient quality.
Raul, can I ask you, can you give an example of a recent effort that was done in one of the clinics? I know at the clinic here, there was an RPIW for hypertension. I don't know if that's a good example, but just something that really illustrates kind of the high level steps involved in the time that it takes for people. I know the group here was out of the clinic for a week to put this RPIW together, but just kind of the steps involved in making this kind of change.
Sure. I think that's a great question. So an RPIW is a rapid process improvement workshop, and it's a really systematic approach to a big problem. So here at HealthPoint, we are focusing on, like, one of our areas is focusing on patients with hypertension. So one of the strategic goals is to look at the patients with uncontrolled hypertension and to manage their hypertension. So we are looking at that whole patient experience. And just when you think about managing hypertension, it's a huge topic. People can spend years just working on that one topic because there are so many different aspects to managing hypertension, and especially in community health centers where patients have so many barriers just in accessing the care, understanding their social determinants of health that get in the way. It can get really complicated. So at HealthPoint, we put together a team, and that team involves people from the executive table to right at the front line. So the MAs and front office people, providers, and all of those people, to look at what the experience looks like. And when you look at this screen, it's called our Envision Future State. So we are focusing on the middle path of our patients, which is the orange patients, chronic stable patients with hypertension. So what Lisa was referring to is we do rapid process improvement workshops like every couple of months to look at a certain aspect of care and really engage the team in looking at the process, understanding the workload and the patient experience, and empowering them to make improvement to that process. So, and it's a week-long process where the team comes together from that clinic and different clinics. Sometimes there are patients involved in co-designing the process, where they look at the process, they improve the process, and then they implement that change. And that gets implemented organization-wide in like the next couple of months. So it's the PDSA approach, where you start testing things on a small scale in a lab, and then you start spreading it out so that it goes in the production stage.
And can you, I'm going to go to this next slide.
Sure.
Can you talk about all these little sticky notes
Yeah. These sticky notes are really, so it's a part of process flow mapping. And what you see in this picture is a process flow map. It's a color-coded system, so each color means something. And the purple sticky notes, for example, mean the high-level process steps. Then the blue stickies mean like the information that's exchanged in that process step. And then the green stickies show how the information is exchanged. And then the yellow stickies are where it shows who is doing that particular process step. And then the yarn is really showing how the flow of information is happening, because information is huge in healthcare, and we often find that sometimes the flow of information is clunky from one step to another, and that's what's causing defects in care, delays in care, which causes provider burnout, and also it affects patient experience to a huge extent. And then all those red stickies are just what's waste in the process. So, for example, the same information is being gathered from the patient at each and every step by different operators, and we don't sometimes take a step back and ask, why are we doing this? So sometimes it's just as simple as asking, why are we doing these things?
And this example was the hypertension and having, and then it was interesting that the team was working together for a week, and then every so often they'd invite the clinic down just to walk through the process where they were, and we had input on each. We were told what they were doing, and we also had input. So it was an incredibly inclusive process, not just if you were in the RPIW, but then if you happen to be in the clinic, you were also included.
Yeah, and like I said, it's a democratic approach. So when it's happening at the clinic, when that team is working on a process, we have systems and mechanisms in place to involve other people working in the clinic. And it's also a great approach to break down the silos. So we had people from dental, pharmacy, behavioral health, and other parts of the clinic to come in and offer their input, so that the team can incorporate their input in designing the process.
And this also gets to, what we're going to talk about next week, which is in creating this culture of wellness. But really, when employees and staff feel engaged in a process, the new kind of talent that's out there, the younger talent, they want to be involved. They want to make a difference. They want to be part of a team that's innovative and contributes. And so, not only that, to me, not only does this improve the systems, but it also engages staff in a way that that hits that bullet of staff engagement. So it's so multi-level.
Yeah, absolutely. And I mean, you said it, like it really speaks to the culture of the organization. And oftentimes it's just an issue of buy-in. But when you think about having created something yourself, buy-in is not an issue, because you have created that. So this methodology really gives and empowers people, the staff, to create something. So they own it and they drive the work, so that the management and the leaders can just remove the barriers, and they don't have to drive things. It's really empowering and trusting the people who do the work.
Yeah, and I see that with trying to now put this hypertension, the plan in place. So now we're kind of piloting here at the clinic. What's coming up as kind of glitches in the systems or things that we need to improve on. People are really engaged in making it work, instead of just kind of complaining about what's not working. They're really working together to smooth out the bumps, so that when this moves to the next clinic, it's seamless. So it's a really exciting process. And I'm going to just click to this next slide and just kind of leave these recommendations of the overall recommendations by the authors of this study. Raul, if you can hang on for the question and answer. But
sure.
These 6 recommendations, adding more clinical assistance for each full-time physician. And again, thinking about, where could that come in budget-wise? If we can see more patients, or we're, over time losing less physicians, can we afford to bring more assistants on? And then needing to train them to the competencies required for team-based care. And that's a big thing that came up in the question and answer with the authors was, the ongoing training that has to happen, in motivational interviewing and panel management, things that people might not be learning in school, but need to be ongoing training within the organization. Electronic medical records need to advance in order to support efficient clinical care, and teamwork. And then the scope of licensure needs to be standardized. Research is needed to inform primary care transformation, and then third-party insurers and policymakers can facilitate improvement in primary care by modifying reimbursement. So that some of these, if we push some of this care out to, local teams, having home visits or phone consultation or care coordinators, are the reimbursement models really in place to do that? So with that, I'm going to kind of end this two-part looking at the In Search of Joy in Practice, really refer you to the white paper and to the study and to the ancillary supports they've created. And then Mariah, do you want to take it over for the question and answer?
Sure, thank you. Thanks to you both for this great presentation today, and thank you to everybody on the line. Feel free to drop your questions either into the chat box or into the questions box on the attendee panel in GoToWebinar, and I'll direct them to our team here. The first question that had come through actually came through a bit ago, so rewinding slightly to the second challenge that you referenced. You were talking about, I believe it was an example with somebody who's now Kaiser, using technology to save time for providers. They were wondering, what is the computer system that was being used in that example?
I actually don't know the answer to that question.
Darn. I figured we'd put in a plug there to see. Yeah, we could maybe see if we could find that information and let you know and follow up if you think that would be possible. We have another question with, so you were talking about co-location, but that sounds like kind of a big overhaul for some folks. Do you have an example of like a good first place to start, and who should be on board when you're trying to make that adjustment?
I'll answer what I know, and Raul, if you have some thoughts on that, but it seems from the research that I looked at a minimum, just having the provider and their either MA or nurse staff co-located, that's a really good first step. Raul, do you want to add anything to co-locating?
I would agree with that. Like, providers and MAs and nurses are the core care team members. And again, it depends on the model of care you have and the type of visits that people do. And but I would say providers, MAs, and nurses are the core care team members.
I hope that answered your question.
Yeah, thank you. We actually don't have any questions in the queue just yet, so if anybody does have a question, feel free to drop it in the chat box and we'll get right to you. But I'll just, as we are nearing the top of the hour here, just kind of go through our close of the webinar housekeeping information. As I mentioned earlier, this webinar was recorded, is still being recorded, and we'll have that available in our YouTube channel and on our website in the next 24 hours. It will be emailed out to everybody who registered for this webinar series, as well as a copy of the slides, so you can go back and kind of refresh your memory on some of the things that were discussed today. Again, there's going to be a very short survey following up this webinar here just to give us some feedback on what you all thought of today and what you'd like to hear in future webinars, as well as next week in round 4, episode 4 of this webinar series, as we continue to discuss ways to reduce burnout in your organization.
And thank you. Oh, Mariah,
yeah.
thank you.
Oh, go right ahead.
Again, Raul Jutar, thank you for joining us and all the participants.
Thanks for having me.
Thank you. It's been great having you both on the line. And thank you, everybody. I think that's it. So I'm going to hit end webinar. I wish y'all a wonderful rest of your day. Thank you.
Thank you. Thank you.
Thanks.